Good evening, everyone. My name is Jerry Harris. I am here to help moderate with the health and wellness sector of the 100 Black Man. Tonight's subject is about multiple sclerosis. We have a Dr. Ayini with us to talk in depth about multiple sclerosis. But before we get started, just a few things, a few housekeeping rules. By all means, if you're not speaking, please mute your microphones. And if there are any questions that you might have that come up, please put them in the chat. And then when I get to them, I will be sure to ask them to Dr. Ayini. And so at this time, I'd like to present Dr. Ayini. He's with the Southeast Permanente Medical Group. Dr. Ayini.
So good evening, everyone. Thanks for joining us. Just like Ms. Harris said, my name is Oluwase Ayeni. I'm a neurologist with the Southeast Permanente Medical Group in Georgia, which is part of Kaiser Permanente. And I specialize in multiple sclerosis, casually known as MS. And so today we'll be talking about MS, including what the condition is, how we diagnose it, and our treatment strategies. Okay. So just to start with an introduction, MS is a chronic inflammatory and degenerative disease of the brain, the spinal cord, and the optic nerve. So it's a neurologic condition that can cause many issues, including cognitive impairment, vision impairment, weakness, and trouble with walking and balance. It's typically diagnosed between the ages of 20 and 40, with about 75% of patients being diagnosed as women. And while it's historically been considered and thought of in the general public as a condition associated with white women, MS can affect any ethnicity, with, in fact, some recent studies indicating that it may occur most often in Black women. And then if a family member has MS, there's about a 1 to 4% chance of a first-degree family member eventually developing MS. And so these are the categories for MS. We'll focus mainly on the 3 at the top, but we'll also talk a little bit about the 2 at the bottom. And so most people get diagnosed with what we call relapsing and remitting MS, with about 85 to 90% of people being diagnosed with this type of MS when they're first told of their condition. And so a relapse consists of acute neurologic symptoms that typically last for days to weeks, and then eventually people recover fully or partially, with about 60% of people making a full recovery back to their baseline. And in between those periods of relapses, people are stable and their disease is not progressing. And that progression component is part of the other 2 major conditions we'll talk about today. So one is called secondary progressive MS, where people actually start out as having relapsing and remitting MS, and then after many years, typically at least 10 years, they can transition to this different phase called secondary progressive MS, where they have a gradual decline in terms of their mobility, their ability to use the bathroom, but even with that gradual decline, they can still have relapses on top of that. And that's different from what we call primary progressive MS, which is what about 10 to 15% of people get diagnosed with at the start. And that's where from the beginning, people have a slow, gradual decline in their mobility, their vision, their ability to use the bathroom. But even after that kind of gradual or slow progression starts, they can still have acute relapses occasionally that even lead to more disability. And then the 2 at the bottom, those are basically what we consider to be potential precursors of MS. So what we call radiologic isolated syndrome, or RIS, that's where people have MRIs that basically look like that of somebody who has MS, but they haven't actually had the clinical symptoms or episodes to actually be diagnosed as having MS. And then we have what we call clinically isolated syndrome, which is where somebody's had one relapse and they have some abnormal testing, either through their MRIs or their spinal fluid, but they haven't met all the criteria, either through their symptoms or through their testing, to be officially diagnosed with MS. And depending on what type of MS you have, that allows healthcare providers to determine how best to treat you and to prognosticate as much as possible what the future will hold for somebody with that specific type of MS. And then the distinction between relapses and pseudo relapses is one of the most important things that we make as healthcare providers. It can be tricky to understand or even to distinguish, but a relapse is what we consider to be a new or worsening neurologic symptom that lasts for at least 24 hours in the absence of an infection or a fever. And this is due to acute inflammation that causes somebody to have these neurologic symptoms that typically last for weeks, days to weeks before plateauing. And we treat that with what we call immunosuppression, or medications to get rid of that acute inflammation, typically steroids for several days. And about 60% of people recover back to their baseline, but that leaves around 40% of people who have some lingering deficits, unfortunately, from their relapse. And that's very different from what we consider to be a pseudo relapse. So the person with MS, it feels like they're having a relapse, but they're not actually having a relapse or new inflammation. They're having a recurrence of their old MS symptoms that are brought out by a stressor. And stressor is a vague term. Generally, it means something that basically puts more pressure or kind of just creates some distress for the body. So for people with MS, the most common stressors are going to be heat, whether that's a fever or they've been working out really hard during an exercise routine, or it's a hot summer day, or it can be changes in their mood or pain or drug use. All of those things can cause their old MS symptoms to be brought out, but they're not actually having new inflammation that needs to be treated with steroids. They just need to have that thing that's stressing their body out be treated. So if somebody's having a recurrence of their previous neurologic symptoms due to an infection, like a urine infection, we give antibiotics, and as that urine infection clears up, their MS symptoms will improve. And this is a diagram of the many symptoms people can have with MS, even though many people think about MS in terms of mobility or vision. MS can affect so many different parts of somebody's ability to function. Fatigue is likely the most common symptom in MS. Mood changes or cognition are often involved in MS. And then basic things like using the bathroom in terms of our bowel or bladder function, and then sensory changes or weakness. And so unfortunately, by the time African Americans are diagnosed, we often have more disease at the time of our diagnosis. It takes people a shorter amount of time to get to that other stage of MS called secondary progressive MS, where they're needing to use something to help them walk, like a cane. And we can often be misdiagnosed as having a stroke or another condition because MS but often isn't thought about as a potential cause of neurologic symptoms, particularly in younger African Americans. And so we're kind of going back to what I said before about many people thinking about mobility or vision as the big kind of characteristics of MS. We know that mental health in terms of our mood and our cognition are heavily involved in MS. So about 2/3 of people with MS will develop some cognitive impairment at some point during the course of their condition. And that often presents as trouble multitasking, or what we call executive function. It can be short-term memory issues, like not remembering certain tasks or not remembering what somebody is looking for when they enter a room, or trouble finding the right word. And then depression and anxiety can be commonly seen in people with MS. And mood changes are one of those things, or stressors, that can actually cause somebody's MS symptoms to worsen, causing what we call the pseudo relapse. And to treat mental health, it can be a combination of things such as medication, therapy, counseling, and just discussing this with people early on. So trying to just broach the subject and let them know that this is very common and that they don't need to feel any sort of stigma associated with it, because it is so common, and not just with people with MS, but in the general public. Estimates are as high as 1 in 5 Americans has some sort of chronic mental health issue. So this is definitely not something that's just isolated to MS or any one specific community, but involves all of us. So what causes MS? Nobody knows exactly what causes MS. Nearly 1 million people in the USA have MS, so about 1 in 300. We do know there are several things that can increase the risk of somebody developing MS. So family history, particularly if somebody has an identical twin with MS, and that kind of ties into genetics. There are different locations on many different genes that have been identified that can contribute to an increased risk of developing MS. We know that vitamin D deficiency, in terms of of your vitamin D levels and your geography in terms of where you live in relation to the equator, both as an adult or even, when our moms are pregnant with us, if they have low vitamin D levels, that can sometimes lead to an increased risk of MS. We know that smoking can increase the risk of people having more relapses or their MS progressing, meaning gradually worsening over time. We know that obesity can increase the risk of MS, particularly in the pediatric population, so people under the age of 18. And then many different viruses have been investigated to see if there's a potential trigger to the onset of MS. Mono, or the Epstein-Barr virus, is one that's often, often discussed or mentioned, but no exact virus has been implicated or concluded to be an actual trigger for MS, but it's always a popular area of research. And then we know that people who have another autoimmune condition, meaning a condition that basically causes their immune system to be overactive and attack their normal body, that if people have one other autoimmune condition, it can increase their risk of having a separate autoimmune condition. So I do have patients with MS who also have type 1 diabetes or psoriasis or thyroid issues, and that can increase the risk of somebody developing MS as well. And in terms of the diagnosis, the first thing we do is just interview people and just talk to people about their experiences and their symptoms. And so people have to have typical neurologic symptoms currently or in the past. So that means even if somebody's feeling completely normal, has no symptoms whatsoever, if they've had symptoms in the past that are typical for MS, that as long as they meet the other criteria, we could diagnose them with having MS. And then MRIs are a hallmark of our diagnosis. So people need to have abnormal findings on the MRI of their brain and or their spinal cord to be diagnosed. And then we don't do this as much these days, but we still often get it, what we call a spinal tap or a lumbar puncture, to collect spinal fluid to look for inflammation that's consistent with MS. And MS is often considered a diagnosis of exclusion, meaning we need to rule out other conditions that could potentially cause those symptoms or cause those abnormal tests. So oftentimes we'll think about strokes or low vitamins, like low vitamin D, or infections that can cause symptoms to be MS. But as long as we rule those out and we, there's no clear explanation, MS is the diagnosis if the person meets all the criteria. And so this is just kind of a typical diagram of MRIs in somebody with MS. So the different areas that are mentioned: juxtacortical, periventricular, those basically refer to the parts of the brain where you see the bright white spots, the MS spots. Infratentorial refers to kind of the bottom or lower part of the brain, what we call our brainstem and our cerebellum. And so these are the spots here. And then the spinal cord, as you can see with that red arrow indicating that bright white spot in the spinal cord. And so because white spots can accumulate or be seen in the MRIs of the brain and spinal cord due to many different conditions, but the spots that we see with MS have a very specific pattern and orientation. And so that's what we look for along with our radiologist to help confirm that we're making the right diagnosis of MS. And so the mainstay of our treatment is what we call disease-modifying therapy. So disease-modifying therapies are the medications that we give to people to prevent their MS from getting worse. So to prevent them from having relapses and to prevent them from progressing or developing disability. And so, before the early 90s, we really didn't have any approved MS medications. We would use other medications to try to get rid of inflammation or control the immune system, including steroids or medications that were sometimes used by the rheumatologists or cancer doctors for other conditions, but we didn't really have any MS approved therapies until the early 90s. And then since then, there's definitely been an explosion of medications. And this slide is, research moves fast, and so this slide is even outdated. There have been new medications that have come out since this slide was published at the end of 2020 and in 2021, with more medications on the horizon. So, even though MS does not have a cure, we're lucky that, it's 2021 and that we have many different choices in terms of how the medications are given, the potential side effects, and how strong they are to offer to people compared to, just 30 years ago when we didn't have any of these choices. And so, as I said, disease-modifying therapy is designed to prevent relapses and progression. So if somebody's having an acute relapse due to their MS or is having current or chronic symptoms, that disease-modifying therapy that we put them on is not going to get rid or treat those issues. It's going to prevent them from having another episode or attack or flare in the future. And we know that early treatment is critical. We know we can do the most for people at the very beginning by getting them on an effective treatment as early as possible. Because even if we get them on a very effective or one of our strongest treatments, if they've been having relapses and they've been getting worse for 2 years, 5 years, 10 years, and slowly building up disability, even if we get them on a really strong or effective therapy, that medication isn't going to do anything for all the symptoms they've developed and all the injury that has accrued in their brain and their spinal cord up to that point. In the old days, these disease-modifying therapies were often given to people when they were diagnosed, and then people were on it till their last days. But we know now that as people get older, particularly into their 50s or 60s, or if they've just done very well for a long time in terms of physically feeling good and not seeing any new inflammation on their MRIs, that they're potentially good candidates for coming off of therapies. And there are several large studies looking specifically at criteria to help determine which type of person would be the most appropriate for stopping therapy. I always encourage people to discuss with their doctor, which medication would be the best for them or their loved one, and how long they would need to be on it. And so there are many different symptoms that can appear in MS, as we've seen on the previous slides. So fatigue is likely the most common symptom in MS. It can unfortunately be very difficult to treat, but we do have different measures that we use to try to make people feel better. So an exercise routine, the goal being 5 days a week of 30 minutes a day of moderate activity of whatever people like to do. There's no perfect exercise, but just trying to slowly build up that exercise endurance and muscle stamina. We know that can help with fatigue. Sleep, I know that seems silly, but talking to people about their sleep schedule to make sure that they're going to bed, as much as possible at the same time every night, that they're getting uninterrupted sleep, hopefully for at least 7 hours. Asking people if they're, taking medications to help them sleep, or if they're snoring, that could be signs of sleep apnea. Trying to optimize all of those things can help with fatigue. We know that diet is a huge area of interest these days and can definitely make people feel better in terms of their fatigue and their other symptoms. There's no best diet when it comes to MS, but there are many that have been investigated and that, anecdotally have been reported to make people feel better, including the pescatarian or intermittent fasting diet and the Mediterranean diet, which is the diet I typically recommend to my patients if they want to follow something. And then stimulants. These are specific medications. You may have heard of medications like Adderall or Ritalin, things that that most people know about in reference to kids who have ADHD, but we also use those medications as stimulants to give people with MS an energy boost. We also use those medications to help people who have cognitive impairment because it can help with focus and attention. And then we also send people with cognitive impairment to see special therapists called speech therapists who can help teach them different coping skills and techniques to try to kind of retrain their brain and help them remember things or plan and sequence things so they don't have as many problems with their memory. Like we talked about before, mood changes are common in MS, and so medication and psychotherapy can help with that. And then bowel and bladder dysfunction, particularly from injury to the spinal cord, are common in MS. And so with that, we do have medications that can help, but we also know that lifestyle changes in terms of getting people on a bathroom regimen, even if they don't feel like they need to use the bathroom, just so they're not under pressure to run to the bathroom or to hold it kind of at inopportune times. Getting people on a schedule where they're using the bathroom every 2 hours or every 3 hours, even though, it can be kind of cumbersome or annoying at the start, can definitely help to get the bowel and bladder function under better control and to prevent, unpleasant accidents. And then we know that certain substances like coffee and alcohol can make us use the bathroom more. So trying to cut those things out can help improve those symptoms as well. And then for people who have issues with mobility, we know that physical therapy, the physical therapist, I probably communicate or interact with them as much as I do with my other neurology colleagues. They're, a huge mainstay of our treatment in terms of helping people get better. And so along with them, medications and equipment, we can definitely definitely help people with their mobility. And then chronic pain, what we call nerve pain or neuropathic pain or spasms, can be common in MS as well. And so for that, things like physical therapy or stretching, medications, and then electrical stimulation can also help with those symptoms as well. I mentioned the lifestyle changes in the healthy diet. You know, there have been a number of diets that have been investigated and continue to be investigated. It's hard to do dietary studies because, you know, it can be very hard to track exactly what somebody's eating, how often they're eating it, what they're putting in their food. And sometimes people may forget exactly what they're eating. But from what we do know and the information we're gathering, there are certain diets that, you know, at least in and case reports or case studies have been shown to be effective for people, not just in terms of making them feel better, but also in terms of biologically, the changes we can see in their blood or on their MRIs can benefit from these diets as well. And so we talked about exercise and avoiding tobacco, cigarette, and cigar smoke, which can be terrible for MS. Medical marijuana or CBD or low THC, that's definitely an industry that is thriving these days all around the country. Unfortunately, it's harder to get access to that stuff here in Georgia. I do have a few patients who are signed up for it, but it's definitely more challenging and still kind of in the early stages compared to some of our other states on the West Coast, like California and Washington. But that is something that can be helpful for people with pain or with spasms. And then, we don't want people to think that because they have MS, they need to, stop what they're doing, quit their job, feel like they still can't do the things that bring them happiness and fulfill their lives. So we definitely still encourage people to continue their hobbies and interests. And that combining these approaches with our specific MS medications for the most comprehensive treatment strategy can really do the most for helping somebody control their condition and helping them improve in the future. Family planning, this is something that has definitely evolved. There is unfortunately not that much information when it comes to pregnancy and MS. The information is limited, but it has definitely grown over the past few years. And the old days, people often used to tell women that, because they had MS, they should not get pregnant. But we definitely know that it is safe for women with MS to get pregnant. And in general, from what we do know, women with MS who get pregnant do better than women with MS who do not get pregnant. But it just takes, basically a treatment strategy and some timing and organization with your healthcare provider just to make sure that everybody's on the same page and we're doing as much as we can to protect the baby and the health of the mom as well. And so for our female patients, we encourage them to be on contraception while taking MS medications because some of them can affect the baby. But it just means that, like for my patients, when they want to get pregnant, I want them to let me know before they start trying to conceive so we can know what we have to do with adjusting the medication to make sure that it doesn't do anything to harm the baby. And for men, they really don't need to stop their MS medication except for one very specific one called teriflunomide or Aubagio. It's one of our older MS pills, not used as often these days, but it is the one for men that they need to stop before trying to conceive. And then sexual dysfunction is common in MS. There aren't really great therapies or medications for women, unfortunately. For men, there are options like sildenafil, which is a generic for Viagra. But if that is an issue, seeing a urologist or a gynecologist can be helpful for those issues. And we talked a little bit about this on the previous slide that, MS does not mean that having MS does not mean somebody's a high risk pregnancy or that they should forego getting pregnant. And that there is recent evidence showing that pregnancy can delay the onset of MS and also help to control it. We know that during the second and third trimesters, the chance of having MS flares goes down. And we also know that exclusive breastfeeding for at least 2 months, hopefully, 6 months, but at least 2 months can also help to keep the condition under control. And even though neurologists serve as the quarterbacks, for somebody's MS care, MS is definitely something that where we utilize an interdisciplinary approach, meaning we have providers from many different departments who work together to make sure that we can come up with a comprehensive plan for our patients. So this includes our mental health specialists who can help people who have mood issues or cognitive impairment, our ophthalmologists because people can have problems seeing or problems with their vision, like double vision, and then our therapists who, work with us all the time, both when patients are admitted to the hospital, but then after, they get out and they're back at home, where they can continue to do outpatient rehab and come up with an exercise program for their own that they can continue to do at the rehab facility or on their own at home or at a gym. And hopefully it doesn't get to the point where people need are having so much trouble that they need more assistance at home. But there are companies and foundations that can help people with acquiring equipment for their home to make it easier to maneuver around their home and make it safer for them to get around. So this includes things like canes and walkers, wheelchairs or scooters. Sometimes people can have what we call foot drop, where they have trouble picking up their foot, so it's kind of slapping the ground or not clearing the ground when they walk, which can lead them to stumble or trip. And so things like foot braces or what we call AFOs can help with that. And then, like I mentioned, heat is a stressor that can cause somebody's MS symptoms to get worse, what we call a pseudo relapse, especially in places like Atlanta, where we have long, hot summers. And so there are companies that provide cooling vests that people can wear underneath their clothes to keep them cool, so their symptoms don't get worse when they're outside or if their body temperature increases. And then these are just two MS organizations that assist people with getting additional equipment or additional help at home to make their lives a little easier. And then COVID, unfortunately, we're still in the middle of the pandemic, and just as everybody has seen on the news, particularly here in Georgia, where our rates of vaccination are lower than they are in the rest of the country. Many of the hospitals are still full, and I have this discussion with all of my patients. The National MS Society came out many months ago, and recommended that everyone get vaccinated. But I still have discussions with my patients who are a little concerned or apprehensive about getting the vaccine. And so just to kind of a quick summary about the issue. The COVID vaccine does not cause MS relapses. We don't have any evidence to show that or support that. COVID can, unfortunately, like many other infections, make somebody's MS symptoms worse. And African Americans, we've been disproportionately affected by COVID, both in terms of the actual number of cases in our communities, but also the percentage of the general population who've died of COVID as well. And then MS itself does not increase the risk of getting COVID, because the medications we use are medications that lower the immune system or suppress the immune system. Because of that, certain medications can increase the risk of people with MS having serious problems if they get COVID, such as ending up in the hospital. And so because of that, those patients are what we consider to be immunocompromised or high risk. So we want everybody to get vaccinated, but especially those people with MS who take medications like that can increase their risk, or have other factors that can increase their risk, such as if they're in a wheelchair, or if they use devices to help them make their lives easier, like people who have tubes connected to their bladder to help them urinate, or people who basically need a lot of assistance with their MS care. Those people are at high risk as well. So we definitely encourage them to get vaccinated too. And then because the mechanism and the way each medication works is different, sometimes the vaccine has to be timed with the way the medication is given. And so I encourage people to talk to their doctor to make sure that they're timing their vaccine shot or shots appropriately with when they're getting their MS medication. And then this is just a slide just about the cost of MS and treating MS. Unfortunately, it is one of the most expensive conditions to treat in this country, right up there with cancer and some of our other chronic illnesses. And so most people would think that as more medications hit the market, because our first meds came around in 1993, that as more medications hit the market, that as medications lose their patents, and as medications are around longer, the cost of those medications will start to go down. But as you can see in this table, that has unfortunately not been the case, and the cost of these medications continue to rise. This is from 2017, but the cost of these medications is still extremely high, talking in the $80,000, $90,000 range. And that's definitely something that, we really need to combat and find a way to fix, particularly these days when COVID has devastated the economy and health insurance plans for so many people. Being able to, provide good, affordable care to as many people as possible is one of the most important things that we're trying to do in the MS community. And then just kind of to summarize, connecting to an MS specialist or an MS center early is, very important. All neurologists, see people with MS, but getting plugged in, at least, even if it's just for one visit, even if that person is, a couple hours away, just getting plugged in to see an MS specialist or an MS center can be very helpful for coming up with a clear and comprehensive treatment strategy. We talked about how early treatment is critical, that we know we can do the most for people at the very beginning, not after they've accrued, a number of relapses and they've progressed in their diseases to the point where, it's really affecting their ability to function. We talked about lifestyle changes like avoiding tobacco, exercising, and trying to follow a healthy diet to help keep MS under control and improve symptoms. And then that if starting a family or getting pregnant is something that somebody wants to do, I always encourage them to talk to their doctor about it, and they should not let MS stop them from having a family if that's something they want to do. And again, just kind of going back to this general idea about MS and in the general public, that it's only isolated to one community, or it's this crippling disease of young people. We definitely do not think about it that way these days, because of the advent of so many of our medications, that we can pick it up earlier, in terms of the time of someone's condition, and that people with MS can lead full and active lives. And this is just a picture of people participating with the National MS Society. That orange color that you'll often see in MS slides or on MS clothes, that's affiliated with the National MS Society, which is one of the biggest organizations in terms of patient outreach, education, and MS research in the country. And these are just some of the MS organizations, like I mentioned: the National MS Society, the MS Foundation, and then the Beyond MS app is an app that people can use on their smartphone or their tablet, just something that they can carry with them that has a lot of helpful information about MS, and also helps to connect people to different resources for MS, including education and support groups. And that's it.
Alrighty, Dr. Ianni, thank you so much. Lots of information here. I will share with the group, back in 2004, I was diagnosed with MS, so quite a few of the brothers in the 100 probably don't know that. But I've managed it very well. Dr. Ianni, you can go ahead and stop sharing your screen if you want to. And so I've experienced, certain conditions, throughout the years, but the good thing is we caught it early. And I've been on Copaxone for it's been quite a long time, but it definitely helped me to manage the illness. So, but to his last slide about leading a full life, most of you know me, so you know what kind of life I lead. So it's I don't let it affect how I go about my daily life. So I still play golf and do the things that you wouldn't even know unless I told you. But it just tells you if you manage it right, you can just go on just like a normal person. So so I do have a question here in the chat from Brother Keith Burbank. In regards to professional football players in particular, because of the collisions are a big part of the sport, are they at higher risk of developing MS later in life than the general population?
No, we don't have any evidence to suggest that football players or players or athletes in other contact sports like boxing or hockey are at a higher risk. That type of trauma, or what we call traumatic injury that can happen to the brain or spinal cord, that does not increase the risk of developing MS.
Gotcha. That's good to know, because I assume that with any injury like that, it could potentially trigger the MS, but that's good information. In regards to early diagnosing, what are some of the questions that somebody who has been a part of this presentation tonight, if they have a certain feeling, a numbness or something like that, questions do they ask their doctors and say, okay, what do I need to do just to test this to see if it's onset of MS or things of that nature? What are some of the questions they should be asking their physician?
Yeah, hopefully no patient or person would ever have to ask their doctor, what type of question or what should we be doing to rule it out? Hopefully a neurologist or a primary care doctor would be able to determine that on their own. And so, like I said, the first thing that we always do is talk to somebody and interview them, because numbness can be a sign of MS, or it can be a sign of many other conditions. And so in terms of talking to them, we get a feel for exactly where on their body the numbness is occurring, how often does it occur, how did it start? And then if somebody has symptoms that are potentially concerning for it, like an entire limb or one side of their body being numb, or an episode of losing vision in one eye, something we call optic neuritis, which is a presenting symptom in about a quarter of people with MS. And can be more severe in African Americans with MS, or people can have what we call transverse myelitis, which can often be a more common presenting episode in African Americans. And when people have transverse myelitis, it can affect their mobility in terms of their weakness, in terms of their strength, their walking, and their ability to use the bathroom. When the doctor is interviewing them and talking to them, getting their history along with the findings that along with what they see on their exam, the things that a person should get to rule that out or to investigate the possibility of MS would be an MRI of their brain and their spinal cord, and just to start there. And then depending on the findings of that MRI of the brain and or spinal cord, they could ask their doctor if they need that lumbar puncture or spinal tap. But it would always start with asking simple questions, and then an exam. And then if there is something concerning, or if somebody's background or history is, concerning for it, like having a family member with MS or autoimmune conditions, then MRIs would be the place to start.
Gotcha. Yeah. And speaking of the optic neuritis, I experienced that back in 2015, where my vision in my right eye progressively got worse. But then by the 7th day, it had already come back. So it was an experience, I should say, but I managed to get through it. You mentioned earlier in your presentation about sometimes where you're geographically located can also increase, or you see more people in particular areas with MS. Can you share with us in the US where that might be prevalent, as well as around the world?
Yeah, so some of this is going to be due to limitation, unfortunately, of data collection. In terms of, so it's estimated there are somewhere between 2.3 and 3 million people in the world with MS. So, somewhere around between 919,000 and 1 million people in the US are estimated to have MS. And then the majority of other MS patients in the world are basically concentrated in the countries of Canada, which is pretty far from the equator and can get cold, and then the United Kingdom, so like England, and then Scandinavia, like Sweden and Denmark, and then other places in Europe. And so there's been for a long time this focus on where a country is located in terms of how close it is to the equator, in terms of how much sunlight and sun exposure those countries get, and how that can play into vitamin D deficiency as a possible explanation for why we see more people with MS in those countries. The truth of the matter is there's very limited data in terms of looking at MS in other continents, particularly Africa, particularly sub-Saharan Africa, and then also in Latin America. The numbers or the rates of MS in those countries are very, very low, but that may be due to the fact that they're warmer climates and they're closer to the equator, but it could also be due just to the limited collection of data in those countries as well.
Gotcha. Okay. For somebody who's on a medication, or if somebody who's happened to be viewing that maybe have a family member or a friend that's on medication, if you've been doing well with a medication, most of my doctors tell me, hey, just stick with what you have. But then, there's new studies, new medications that are always coming out. They have one, I believe, that you take it once a year, or something of that nature. And so that one time that was appealing to me, but then they said, well, it hadn't really been tested a lot. And I said, well, let me just stick with what I got versus switching over to that. So what would you say to someone that may be on the fence of, maybe I need to switch from this Betaseron to Copaxone or to Rebif or something of that nature?
Yeah, so particularly for those people who are on what we sometimes are referred to as platform therapies, or kind of our ABC treatments. So Avonex, Betaseron, Copaxone. So kind of our older school injection treatments from the 90s. If people are doing completely fine on those, meaning they feel good, they're not having intolerable side effects, and their MRIs are stable, I don't believe there's any need to switch somebody to kind of the newest and shiniest medication, even if it is more powerful. Because if they're doing well on a medication they've been on for years, that means that they don't necessarily need to change or necessarily need to move to something stronger. I do encourage people to talk to their doctors about switching if they're having relapses or if they're not able to tolerate certain medications, or if the medication they're on either interacts with one of their other medications or potentially can imperil the status of another medical condition they have, then it's possibly a good idea to switch to a different medication, or discuss one of the newer agents, particularly those that don't have to be given as often. I believe you're referring to infusion therapies. But for people who are doing well on an established medication, I don't think there's any need to switch them.
Gotcha. That's good to know. So we have Brother Curtis Adams, who's a 100 Black man brother from Rome, Northwest Georgia. And he says he was diagnosed in 2000 with RRMS, which is remitting relapsing MS, if I remember correctly. His eye doctor actually discovered it, and concurred with the doctor that the Shepherd Center, MS Center, was an excellent resource. Yeah, that used to be where I used to go as well. And could you speak to the overwhelming fatigue that can happen in some MS patients?
Yeah. So fatigue, like I said, is likely the most common symptom in MS. Sometimes people refer to it as a lassitude, kind of an older medical term, but fatigue is extremely common, and it can just be kind of a crushing or debilitating fatigue that doesn't go away even if people are sleeping well. So, I'll see patients who say, I sleep 10 hours a day, 10 hours a night, 12 hours a night, uninterrupted. I wake up and I still feel exhausted. I still feel like I have to nap during the day. It is one of the most challenging symptoms in MS to treat. But we do have kind of approaches or therapies that can help. There's always going to be, almost always, there's going to be a medication for a symptom. I like to, as much as possible, start with lifestyle changes or other approaches to helping with fatigue. So start by talking to somebody about their sleep schedule, especially given how common obesity or snoring is in America these days. Talking to people and evaluating them to see if they have sleep apnea, meaning they're not breathing enough or getting enough oxygen when they're sleeping, and that can be a really big contributor to fatigue. So if we can get them a sleep study or get them that shows sleep apnea, and get them a CPAP or help them with weight loss, that can really help with their fatigue. And then getting on an exercise routine, that can definitely be very challenging as well, because when somebody's exhausted, they don't want to work out 5 days a week of 30 minutes a day. It can be a huge struggle, especially after that first day. They'll often feel completely wiped out the next day. But just trying to encourage people and tell people that this is a marathon, it's not a sprint. And even if you can only start out by walking half a block, or walking for 10 minutes, just trying to slowly build up your endurance and stamina every day can definitely help with the fatigue as well. And then the stimulants that we use, like Adderall and Ritalin, or there's a medicine we use called Nuvigil or Provigil. Those are medications that can help as well. They don't have to be taken every day. They can just be used on an as needed basis, which is a strategy I use with many of my patients. So, we talk about the lifestyle changes like exercise, diet, and sleep, but then we give them these stimulants to use, if they're going to have a really long work day, or, they have, a really long social engagement, to use, one or a couple pills in the morning to help them get through the day. But then on those days that won't be as taxing, or on the weekends, to take a break, so that they don't, become tolerant to the medication or don't become addicted to it.
Gotcha. Great. So I'm going to go back to your geographic statement earlier. And this is purely for my pleasure. And if I could share this information with my wife, if you tell me that if I moved to Hawaii, that my MS would stay on the even keel, I'm going to put a for sale sign in my yard today.
It would not, no. It would not. Yeah. In fact, one of my one of my old mentors, he trained in upstate New York, so, which is obviously very cold, like Buffalo and those places. And so, there's a good number of people with MS there. But then they moved down to Georgia, and they, still saw a high number of people with MS here, even though, there are far more Black people here in Georgia than there are in upstate New York, and our climate is much warmer. So while Hawaii, I think, would be a wonderful vacation and move for you, I don't think it would get rid of those symptoms.
Gotcha. Well, we have about 15 minutes left. I'm gonna actually open it up for if anybody that has a question that's on the Zoom chat. So by all means, unmute your mic and then go ahead and ask your question if you have any. Well, then question about symptoms. Now, I know I mentioned that, my symptom lasted about 7 days. Is that common with MS patients, is that it's about a 7-day turnaround where it bottoms out about the 4th day and then it starts to improve? It's almost like a V type of thing that happens that, you hit rock bottom here and then it starts to improve on the way back.
Yes, everybody's situation is unique. To that relapse definition, it has to last at least 24 hours. Most people will have symptoms last for days to weeks. So when I say days, most of the time it'll last at least 3 or 4 days, and can go on for several weeks. Even up to and past 4 weeks. And it depends on how bad somebody's relapse is. So for optic neuritis, most people will kind of hit their what we call nadir or bottom out around day 14. Day 10 to 14. And then after they hit that bottom, they'll slowly start to improve. And they can improve spontaneously, or the improvement can be hastened with the use of steroids. And about 60% of people do return to their baseline. Unfortunately, that leaves approximately 40% that, still have some lingering effect. But people can continue to recover for a long period of time, even after they finish their steroids, even weeks after they've had their event. So even for our optic neuritis patients, even if they've had steroids, if their vision isn't completely back to normal, or to the point where they can't really notice any issues, like 6 or 8 weeks after the onset of their symptoms, they shouldn't be discouraged, because, oftentimes I'll see those people and I'll see those people in tandem with ophthalmology, the eye doctors, and every successive visit will continue to see improvement. And even for those patients, there's been research to show that their eyes or their nerves can continue to improve even up to and past a year from the onset of their symptoms. But for most people, it is going to be days to a few weeks where their symptoms slowly progress. But it also depends on how bad it is and how many areas of their nervous system are involved. Because if you have somebody who has inflammation just in their eye, their timeline and their recovery, could be very different from someone who has inflammation in their eye, their brain, and their spinal cord slowly getting worse and causing a great amount of dysfunction.
Gotcha.
I have a question.
Go ahead.
I want to ask the doctor. So I've had a problem with sneezing, right? So these sneezes, I was driving one time and I kind of blacked out. And my wife grabbed the steering wheel, but I could see her grab the wheel, but I wasn't consciously there. And so I haven't had that happen again. But I have these sneezing fits that cause my whole body to spasm, where it kind of locks up. Have you heard of that before? Have you seen that before?
Yes, I've not heard of sneezing inducing, that type of spasm. When somebody sneezes or coughs, especially if it's a big sneeze or if it happens continuously, it can kind of put pressure on different parts of the body and lead to changes in your blood pressure. And so sometimes that can cause people to feel kind of faint or lightheaded. Or if somebody's in distress, they're coughing or they're sneezing, they're having trouble breathing or swallowing, or they're just in a lot of pain, that kind of stress or pressure on their body can bring out MS symptoms. And people with MS can have what we call paroxysmal or temporary spasms, often due to areas of MS injury in their spinal cord, where if they have some sort of stressor or something putting pressure on their body, it can cause them to have, kind of a full body movement or a spasm that can be very painful or uncomfortable. Yeah, but sneezing usually isn't something we think about that MS would cause, but definitely, like recurrent sneezing or coughing or some issues kind of breathing, that could bring out some of your old MS symptoms. But if the sneezing is a big issue, I would encourage you to talk to like your primary care doctor or an ear, nose, and throat doctor if it doesn't go away.
Okay. Because normally it'll be like 5 sneezes in a row. I know I'm going to spasm.
Okay.
5 in a row, I know spasm at that point.
Yeah. And there are medications that you can use on they can be taken every day or on an as needed basis to prevent the spasm. But really the best thing would be to kind of identify what's causing that sneezing. If it's like an allergy issue or a sinus issue, so they can get at that and treat that instead of giving you, a prescription medication that has potential side effects to prevent the spasm from happening.
Okay, thank you.
Hello.
Thank you, Daryl. Appreciate it.
Can you hear me?
Yes, go ahead, Richard.
Yes, Jerry. I'm traveling. I've jumped on kind of late, so I don't want to have redundant information. If you can just briefly give me like a couple of symptoms. Like I said, I know I'm late, but I just wanted to hear just like a few symptoms that that's associated with MS.
Yeah, so fatigue is likely the most common symptom in MS, sir, where people can feel extremely tired, excuse me, even if they, have a good night of sleep, or, even if they're somebody who's always been able to have enough energy by drinking their morning coffee, but they're still feeling really tired. Cognitive impairment, which we consider to be issues with their thinking. So for people with MS, that's most often going to be attention or concentration issues, or they have trouble multitasking or keeping things organized, or they have trouble with a short-term memory or kind of word finding difficulty where they say the right word. MS symptoms can often look like people are having a stroke. It's just that meaning they can have like weakness on one side of the body or numbness on one side of the body, but as opposed to a stroke where somebody's doing completely fine and then boom, all of a sudden, they can't move one side of their body or their speech gets slurred. Typically MS symptoms don't start that rapidly. They'll progress over the course of a couple days, but the symptoms can look very similar. And then bowel and bladder dysfunction are also common in terms of people having to rush to the bathroom to urinate or defecate, where they can't control their bowel or bladder function, so they're having accidents, or they need to use adult diapers, like Depends. And then there's a type of pain we often see called nerve pain or neuropathic pain, where people can have pain in an entire limb or one entire side of their body, or they can have tingling like in their hands and feet, that can be very troublesome or frustrating, and that is also a common symptom in MS too.
Okay, thank you.
How much for just a thing of guac? If I just want a thing of guacamole, how much is that?
It's $2.50.
I'm sorry, somebody's in the grocery store and did not mute their phone, so they're looking for guacamole.
I muted him, Jerry. I muted him.
You got him? Okay. I'm not sure who that is, but I hope he finds his guacamole.
It sounds like Ronald.
So we did have another question. Kevin Williams, go ahead and ask your question, brother.
Sure. Appreciate it, Jerry. Thank you, Dr. Tu, for your time this evening.
Of course.
Listen, you put out some great information, some wonderful information. Will we be able to get a copy of these slides? Because there were a lot of hyperlinks that can lead to some answers at least.
Yeah, Mr. Harris, were we going to make the slides available for them?
Yes, we will. I will make sure I get those to Dr. Vaughn, who's doing a fantastic job of putting on this health and wellness segments, and I'll be sure that he gets it, and so that he can send it out to the group. So we have about 5 minutes left. Were there any other questions? Oh, that was Ron Skeet, Taco Tuesday. Okay. But if there are no other questions, I'll just go ahead and share my screen real quick. Just to let you know that we'll have another virtual conversation coming up on October 19th. Brother Reverend Tracy Harris will be the moderator and talking about domestic violence. So be sure to tune in for that. Once again, Dr. Ayina Yini, forgive me. We thank you so much for joining us. We appreciate all the information that you've shared with us. I've even learned just a few things, even being an MS patient. But we really appreciate you spending a little bit of time with the 100 Black Men in North Metro and sharing with us about the disease MS. So any closing words, sir?
No, just thank you so much for having me. And kind of just to encourage people, it's always okay to ask questions. You never have to feel, like your doctor is some sort of supernatural being or will be offended if you ask questions or, kind of propose alternatives. And if you don't feel comfortable, it's always okay. Just like I said, kind of seeking out an MS center or specialist early, it's always okay to ask for a second opinion, if you're feeling concerned or if you're not convinced.
Absolutely. Well, we thank you so much. Dr. Arthur Vaughn, is there any closing messages?
No, Doc, I want to thank you again. As soon as we contacted you, you were like, sure, I'll do it. And I appreciate your willingness and the National MS Society and the work you do there. And we just want to thank you for giving up your time, and for everybody that tuned in, thank you for giving up an hour on your Tuesday when it's any other thing you could be doing to be here with us. So thank you all. And thank you, Jerry, for being our moderator this evening. We really appreciate it.
Not a problem at all. You all have a great evening, okay?